Thank you very much. Thank you. Last session of the day is going to be a closing keynote lecture by our friend Thierry Corcos. I think he has recorded his presentation, but he's so kind to be with us. Now, I know that he's not in France, he's somewhere else, but he has really taken the time to be with us for this closing ceremony. Of course, I'm pleased to have with us Horst Sievert and Kees Batik. So the keynote lecture is entitled Artificial Intelligence Cardiology, and I'm sure it will be very interesting. So can you run the recording, please? And then we will have Thierry for questions later on. Thank you.
Okay.
Good afternoon, dear friends and colleagues. I'd like to thank Habib Gamra for his kind invitation to participate in this meeting. I'll never get sick of Pafcic. When I say artificial intelligence, you might imagine robots such as the Terminator. Actually, with smartphones, geolocation, carpooling, email, banking, social networks, online shopping, self-driving cars, artificial intelligence is already dominating our lives. Artificial intelligence refers to the broad concept of simulating human intelligence and its application for specific practical purposes. Like a Russian doll, it encompasses machine learning and deep learning. Machine learning belongs to the family of algorithms that share the ability to learn and optimize tasks such as prediction and classification. It's capable of learning from data and doesn't depend on explicitly programmed instructions or mathematical assumptions. Finally, deep learning is able to adapt and learn from a considerable amount of data. The convergence of three forces sparked the artificial intelligence revolution. Big data with unprecedented storage capacity, considerable computing power with the advent of graphics processing units, and refinement of calculation methods thanks to algorithms, which are finite sequences of well-defined instructions that can be used to solve problems or perform a calculation. Data is increasing at an exponential rate. The quantity of data doubles every 15 months, with over 90% of all data in the world created in the last 2 years. It takes the same amount of computing to answer one Google search query as all the computing done in flight and on the ground for the entire Apollo program. Until now, according to Moore's law, there was an exponential increase in computing power with a doubling every 2 years, parallel to the number of transistors in integrated circuits. But since 2012, thanks to artificial intelligence, computing power has doubled every 3 months. The exaflops barrier 1 billion operations per second was first broken this year. Machine learning is the use of a set of algorithms to analyze data, learn from it, and then determine and predict a set of events. Instead of writing code for a specific program using a set of instructions to accomplish a task, machines are trained with a set of data and algorithms that gives them the ability to learn how to execute a task. There are several machine learning algorithms. The name algorithm comes from Muhammad ibn Musa al-Khwarizmi, a Persian polymath who was born in Khiva, now in Uzbekistan. Deep learning is based on artificial neural networks. An artificial neuron is a mathematical function, like a biological neuron, with the postsynaptic facilitating and inhibitory potentials in the dendrites and the action potential in the axon. The artificial neuron receives one or more inputs and adds them together to produce an output. Usually, each input is separately weighted and the sum is passed through a nonlinear function known as the activation function. A traditional artificial neural network consists of an input layer, a hidden layer, and an output layer. To optimize the model's performance, the model weights are adjusted during each learning cycle according to the differences between output and ground truth. This process is called error backpropagation. Deep learning networks have several hidden layers. A convolutional neural network can be used to progressively extract ever higher level representations of image content. It uses only the raw pixel data of the image as input, learns how to extract features such as shape and texture, and finally infers the object they constitute. Frenchman Yann Lequin developed this convolutional neural network and is now director of artificial intelligence at Facebook. The accuracy of traditional machine learning reaches a plateau as the amount of data increases, as shown in the red curve. On the contrary, as shown in the yellow curve, the performance of deep learning increases with the amount of data to be analyzed. Because data is the new electricity, GAFAM companies, Google, Apple, Facebook, Amazon, and Microsoft, are now the leaders in artificial intelligence. Thanks to deep learning, computer vision, and especially image recognition, has now an error rate of 2%, which is much lower than the human error rate of 5%. This is why in medicine, artificial intelligence has been shown to be at least as reliable as dermatologists, radiologists, pathologists for the diagnosis of cancer, and then ophthalmologists for the diagnostic of diabetic retinopathy. Actually, via deep learning, a simple retinal fundus photograph predicts most cardiovascular risk factors such as age, gender, smoking status, diabetes, overweight, hypertension. The incorporation of artificial intelligence into cardiovascular medicine will affect all aspects of cardiology, from research and development to clinical practice to population health. The central promise of machine learning is to incorporate data from a variety of sources: clinical, biological, omics, imaging, digital health, into sensible models for describing and predicting human disease. Echocardiography remains the predominant imaging modality for the timely and cost-effective evaluation of cardiac structure and function. Machine learning has several applications in clinical echocardiography. It can provide a fully automated analysis as well as use detection of coronary artery disease on resting transthoracic echocardiography and use of strain distribution for the diagnosis of amyloidosis, constrictive pericarditis, and hypertrophic cardiomyopathy. In cardiac CT, machine learning has been used in three main areas that are strongly interconnected: dose reduction, automation of tasks that could otherwise be performed by a human, and generation of new clinically important knowledge. Deep learning can reduce the radiation dose by 80% by converting a low dose noisy image into an image similar to a high dose image. It can detect coronary calcifications on each vessel and automatically calculate the calcium score without human intervention. It can automatically detect coronary arteries and quantify the plaque with standardized measurement of the maximum stenosis in diameter and cross-sectional area, non-calcified plaque volume, calcified plaque volume, total plaque volume, plaque burden, lesion length. It can characterize high-risk plaques, severe stenosis, positive remodeling, low attenuation plaque, napkin ring sign, spotty calcium. The visualization and quantification of low attenuation plaques allows the identification of plaques at risk of infarction, either spontaneously or during stent implantation. Radiomic analysis is a new field of research. Here, the plaque voxels are extracted from the image. Hundreds of descriptors of heterogeneity and spatial complexity are computed to create big data databases, which are analyzed using machine learning. Current computed tomography systems allow accurate and reliable evaluation of myocardial mass at risk, which is an important element in the therapeutic decision. They can reliably evaluate myocardial perfusion imaging at rest and during pharmacological stress in the same examination. This requires more radiation, but makes computed tomography the unique non-invasive one-stop shop method for a comprehensive evaluation of anatomical coronary atherosclerosis and its physiological consequences. Deep learning analysis of left ventricular myocardial in a single CT scan acquired at rest can even be used to identify patients with functionally significant coronary artery stenosis. This doesn't require supplemental radiation for a stress protocol and might reduce the number of patients undergoing unnecessary invasive FFR measurements. On-site CT FFR based on machine learning from DICOM raw images improves coronary CT performance by correctly reclassifying hemodynamically insignificant stenosis and works as well as CT FFR based on fluid dynamics and invasive FFR. Epicardial fat volume, shown in red in the image on the left, is a new biomarker of coronary artery disease that can be calculated without contrast injection. More recently, fat density immediately around the coronary arteries has been evaluated during CT angiography. The perivascular fat attenuation index captures coronary inflammation and predicts mortality beyond current risk stratification approaches. It has the potential to advance cardiac CT to a dynamic cardiac risk stratification tool applicable even without coronary plaques or substantial calcification. In nuclear cardiology, artificial intelligence will provide highly accurate tools to detect disease, stratify risk in a more consistent manner, and optimize patient-specific management. In magnetic resonance, artificial intelligence will improve image reconstruction and image quality, segmentation and quantification, reporting, and patient management. What about the ECG? Using deep learning, a simple 12-lead ECG can detect low ejection fraction. Smartphone fitness applications are routinely used to assess cardiorespiratory fitness in clinical and sports context. Smart devices such as smartphones and smart watches are already increasingly used in daily clinical practice. Last year, the Apple Health study showed that among patients notified for an irregular pulse, the positive predictive value was 0.8 84 for observing atrial fibrillation on the ECG simultaneously. This could be a feasible approach for atrial fibrillation screening. New devices, such as on the left, a live core with 3 electrodes, 1, 2, 3, can record a mobile clinical quality ECG with 6 leads. CardioSecure on the right with 4 electrodes can record 12 to 22 leads, making the diagnosis of arrhythmias and acute coronary syndromes possible. In heart failure with preserved ejection fraction, using dozens of clinical ECG, echo, and biological variables, machine learning can stratify patient risk. What about risk calculators? Using the same 9 variables as the ACC-AHA risk calculator, the machine learning risk calculator outperformed it by recommending less statins, yet missing fewer cardiovascular events. Machine learning incorporating coronary calcium score improve the ability to rule out the presence of obstructive coronary artery disease. For CT angiography, for 5-year mortality prediction, machine learning in red outperformed Framingham risk score in light blue, and all scores derived from CT angiography in dotted lines. What about voice? Voice is a rich source of information well beyond words. Inflection and tone provide a window into the state of mind and physical health. Therefore, voice might serve as individualized vocal biomarkers. Research is underway to examine the diagnostic potential of using voice analysis in a range of conditions, including coronary disease. In the cath lab, a virtual reality headset can provide the patients with a fully immersive experience in order to relieve anxiety associated with their procedures. FFR can be derived from coronary angiography. 3-dimensional arterial anatomy is reconstructed from paired 2-dimensional angiogram images. It has the potential to eventually replace Y-based FFR measurement and substantially increase physiological coronary lesion assessment in the cath lab. The evidence for the application of and benefit of the extended realities in cardiology is building, spanning from education and training to cardiac patient rehabilitation, and from pre-procedural planning to intra-procedural use. Hardware innovations have increased the fidelity of the 3D visualization, enabling greater immersion during patient therapy, improvements in learning comprehension during medical training, and improved understanding of patient-specific anatomy before and during patient procedures. During a robotic-assisted intervention, physicians sit in a radiation-shielded workstation and use a set of joysticks and touchscreen controls that translate the physician's movement into device control. Robotic assisted intervention enables precise measurement of anatomy and device positioning, with the added benefit of radiation protection for the physician and the potential to reduce radiation exposure for staff and patients. The artificial intelligence enabled future cath lab may look like this, with clinical decision support system, voice-powered virtual assistant, augmented reality platforms, and semi-autonomous robotic system. In conclusion, cardiologists tend to have access to rich quantitative data on patients compared with other specialties. As the amount of available patient-level data continues to increase, we continue to incorporate new streams of complex biomedical data into the clinic. It's likely then that artificial intelligence will become essential to the practice of cardiology. This will probably happen sooner than later, as exemplified by the rapid adoption of automated algorithm for computer vision in radiology and pathology. Artificial intelligence will drive improved patient care because we will be able to interpret more data in greater depth than ever before. Cardiologists should therefore take a lead in deciding where to apply and how to interpret these models. Thank you for your attention.
Very much, Thierry, for this fascinating lecture. Futuristic, talking about the future, but a lot of information and very positive thoughts, by the way, for us as cardiologists. And I wonder if there are any questions to Thierry. But in the meantime, I just would like to ask you a question, Thierry. You know, you have shown us that I think artificial intelligence has already helped us, particularly in terms of screening, for risk calculation, etc. But for intervention, because you're an interventional cardiologist, do you see any future in terms of help artificial intelligence in intervention? For example, you know, it would be really helpful for us to have something that help us go through difficult situation, like the case that was presented by Maximo today, which was to cross a very tortuous lesion to measure FFR, and the patient who has nothing, was asymptomatic, end up with dissection of the vessels, etc. Do you think any way that we can have the assistance of artificial intelligence in such conditions where we have issues, we have problems, our interventionalists? Thierry, we cannot hear you, Thierry. Can you get closer to the mic? If your phone or microphone. No, you're on mute.
Can you hear me?
Now, better.
Great. Okay, I was just, artificial intelligence is already there. There are lots of applications. We don't know there are artificial intelligence. In the real life, for instance, when you receive a mail and it's classified as spam, it's artificial intelligence. It's been here for decades. So in the cath lab, that's the same situation. You're referring to clinical decision support, I believe. I think there are lots of situations where we could have the help of the machine to tell us what to do. First, to detect clinical significant stenosis with FFR angio, which could be a wonderful application of artificial intelligence connected to regular coronary angiography, but also that it could help us for taking decisions in some situations because the machine will know what problems our colleagues have had in the same situation and what would be the best decision to take.
Actually, Habib, if I may ask a question, actually, I would like to rephrase your question. Thierry, can you imagine anything in medicine which cannot be replaced by artificial intelligence at the end? Any decision process, any diagnosis, or any treatment?
I agree with you. Since these are data, it can be analyzed by machine, but the machine will never replace the physician. Machine has no empathy. So the machine will help us. It will save time. It will make us analyze data in greater depth, and it will save our time, but it will not replace us. There has been a huge discussion about the usefulness of radiologists in the future, because some engineers have said that we will not need radiologists in the future. The machine will do everything, positioning the patients, doing the test, interpreting, making the report, etc. But I don't think that would be the future. In the future, it will help us, but we'll stay there.
Okay. It's quite reassuring that we stay there, so it won't be replaced by the machine. Okay. Now, Thierry, just again, maybe the last question. It's the question of reliability. For example, when we have the CT FFR came out, we were really hopeful that that technique would gain acceptance and that we not have to go through FFR by angio, because again, if you have the information prior to the procedure, you're much more comfortable. You take the patient straight to the cath lab and you treat the patient. But it does not seem that this CT FFR is gaining acceptance. So artificial intelligence is okay, but we need to have reliability and make you really sure that it provides us reliable information that we can take into account. What are your thoughts about this?
There may be a discrepancy between CT-FFR and invasive FFR in some cases, but can we rely on invasive FFR? What do you think?
Yeah, okay. We want to do things ourselves. We are sure about what we do, you see what I mean? I mean, this is maybe human, so...
But it's also when you do invasive FFR, it's also a machine that does the work. And now with the machine learning, we don't have to send the data to waste time. We have immediately the result of FFR very quickly. So I think I'm very enthusiastic about angio FFR. I think it will be a revolution for interventional cardiologists. What do you think, Horst?
Well, I missed part of the discussion, but I absolutely agree. This will change the way how we do coronary interventions. There's no question about. And coming back to my comment, so when you look at FFR, then we need a doctor currently to decide whether the FFR value is a correct one or not. Maybe there's some mistake in the measurements or whatsoever. But I think also this can be replaced by machine learning, because the computer may be able to detect, the guiding catheter is obstructing the lumen, or something is wrong, and so this can be replaced by machine learning. And also the consequence: should I do something with an FFR of 0.75 or not? This can be done by a machine, because the machine can know the history of the patient, can know other data, and can combine this, and can then also look at the morphology of the coronary artery and make a decision, this is a good case to proceed and put in a stent or not. So I think I cannot, I mean, I'm not an expert in intelligence, and even not, for sure, not in artificial intelligence, but I cannot imagine anything which cannot be done by machine learning systems. Not anything, even empathy, because I mean, there are computer games. People on these computer game consoles, they talk to their partners, which are virtual partners in the computer game. Some of us, I don't have that, but some of us has this Amazon thing in their living room where they talk with Alexis. So it's sometimes we talk to call centers where we have an automatic voice detection and speaking system. And I mean, this can be done in a way which also suggests some sort of empathy. So I'm afraid, I hope only in 50 years or so, when all of us will be retired, including Habib, you, but I think everything can be replaced.
Okay. Last question, Thierry. I mean, how does it work? I mean, in practice, who is pushing for artificial intelligence? This is an engineer work, right? Is it us physicians are asking for, you know, some help from engineers, or the industry is pushing? I mean, how is it functioning? Can you tell us?
Google.
Huh?
Google is pushing it.
Everyone, yeah, everyone. It's the GAFAM are pushing it for it because they have our data. They have all our data from the internet, from Facebook, etc. They are the leaders in artificial intelligence. The industry works on it. Some doctors work on it. The problem is the interface with the engineers and the doctors, because it's a completely different culture. So we have to be more involved in artificial intelligence, because we need to be associated to engineers, because they know the mathematics, the algorithms, and we have to tell them what we need really. And it has been very successful. For instance, in ophthalmology, with machine learning, the machine is better than the ophthalmologist for the diagnostic of diabetic retinopathy. For the diagnostics of cancers, it's better than the dermatologist and radiologist and oncologist. So it's already there. It's just we cardiologists have to be more involved in it, because it will come sooner or later, and rather sooner than later.
All right. Okay, Thierry, thanks very much. That was a very fascinating lecture and a very fascinating field, by the way. We need to keep exploring this and knowing more and more. So maybe next year we will invite you and tell us what happened.
Thank you very much, Habib, for invitation to this beautiful
Thank you so much. I think we're closing this Congress. It has been absolutely fascinating 3 days. We had a quite high number, not expected at all. We have the first day we had 370 participants. Yesterday 400. Today 450. And the first day the system has broken down because it has not accepted the number of people who wanted to participate. So we had to upgrade on Thursday evening. We had to upgrade the system in order to be able to accept the number of participants who wanted. So it was really not really expected, and we're really happy and glad to have that. Now at this time we have 120 people connected. So it's quite interesting to know. So this virtual way of learning, it looks like it is quite interesting for people, maybe easier than having the face-to-face, although the meetings in person is not replaceable. I think this is something that is really important for us, and we need to have that, and hopefully next year we can see each other in person. Now, I just, before asking Horst to say a few words, I just wanted to thank all the faculty members. There are a good number of colleagues who have accepted to participate with us. I would like to thank particularly those who have had live transmissions. We had more than 10 centers who have transmitted from their centers, either live or recorded cases. I would like to thank, of course, my friends, my co-directors, particularly Professor Ben Farhat, who is our mentor, and Horst Sievert, who has helped us not only during the meeting, but before the meeting in the preparation, and giving us advice for a few colleagues to participate. Qais with us, he has done great work. Dr. Betbout, Dr. Fahmy Ramadi, Mohammed Sobhi from Egypt, the co-director of Pafcic, but very dynamic, and he has helped a lot. Ahmed Suleiman from Sudan, Mohammed Jilan from Kenya. Alain Kribier is also co-director with us, and he has done a great job with us despite some health issues. He was able to participate, and even yesterday after his recording, he visited us and shared with us the TAVI session. All the scientific committee, a good number also from Africa and beyond, they need really great thanks for their contribution. Of course, the industry, we need to thank them. There are no too many this year because they have some economic issues and they were not all of them available to contribute, but it's fine. Those who have accepted to support us, we really thank them very much. I just would like to also to recognize the contribution of Shakil Qureshi has helped us a lot in preparing two important sessions on pediatric cardiology, and I just would like to transmit the thanks of the pediatric cardiology community to Shak for his contribution, and of course, and not at last but not least, Millizima, this company that is organizing the meeting. They have done a great job, really outstanding. Technically, the meeting went very smoothly, either with recording or not. And I can tell you, they have worked during the 3 days, day and night. And of course, they have started the preparation several days before the meeting. So again, thank you all very much for making out of this meeting and this edition a success. And hopefully next year we will have the chance of meeting together. It's planned to be in Marrakesh once again. So Thierry, you can keep it. We have already the agreement with our Moroccan colleagues. They are hoping for the best too, because we're going to be doing that together, but together only if we get rid of COVID-19. Otherwise, we'll stay at home and have a virtual edition again, which we don't like to have. Horst, any final word? We don't hear you. I think you're on mute.
Okay. So I think you said almost everything with one exception, and that's something you cannot say. I would like to say that on behalf of all faculty and attendees, to thank you for all your efforts to put this together. I mean, many people think that doing a webinar conference is less work than a physical conference, but I know from our own experience, it's really the opposite. And I really would like to thank you for that, what you did for this Congress, organizing all these different sessions involving so many.
We lost you, Horst. He's frozen, but I think we understood his point. But again, just to follow what he just said, I mean, this is a teamwork. It's not the work of one individual, as you know. And Thierry knows this very, very well. It's a teamwork, and one person cannot do anything with himself. Qais, any last words before we go back to us, perhaps? Hopefully.
Thank you, Professor Habib. I would thank all attendees also to be here with us and to be behind the Pafcic everywhere when we were in Africa and even on the web. So thank you for being here with us.
Thank you, Qais, for your contribution. Horst, we're back, so you can.
Hello?
Yes, we lost you. Horst, are you back? I think we need to wait for him until he comes back. He's not in Germany. You don't have these internet connection issues in Germany usually, so he's somewhere else. Hello, Horst. Are you back? Horst?
Hello, can you hear me now?
Yes, we can hear you now.
You are coming and going. It's really a that's a disadvantage of these webinars, that you get interrupted very sudden. So that's really a technical problem we have to work on to make the internet available everywhere. And
okay, I will give you a trick. This is my thing. This is my companion now, because to avoid any this is artificial intelligence, maybe Thierry. So I have this device with me wherever I go, and I have a very high speed internet, even in my hospital, even at home. I would not allow my kids to use it, and it's a very reliable system. So you don't rely on other systems; you rely on your own that you have with you. Horst, are you back? Otherwise, thank you again very much, dear friends, dear colleagues, dear attendees, and hopefully we'll see you next year in person. Bye-bye.